Morning class. Today we're going over chapter 33, OB and neonatal care. Special patient populations applies fundamental knowledge of growth, development, and aging, and assessment findings to provide basic emergency care, transportation for a patient with special needs. OB, recognition and management of normal delivery, vaginal bleeding in the pregnant patient, anatomy and physiology of normal pregnancy, pathophysiology of complications of pregnancy, assessment of the pregnant patient, management of normal delivery, abnormal delivery, nuchal cord, prolapse cord, and breech delivery. Third semester bleeding, placenta previa, abrupto placenta, spontaneous abortion, miscarriage, ectopic pregnancy, preeclampsia, and eclampsia. Neonatal care, assessment, management, and newborn care, neonatal resuscitation. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Special considerations in trauma, recognition and management of trauma in the pregnant patient, pathophysiology, assessment, and management of trauma in the pregnant patient. Introduction, most deliveries occur in a hospital. Occasionally, a pregnant woman is unable to get to the hospital. You must then decide whether to assist the delivery on scene or transport the patient to the hospital. So this is a good idea to know when the contractions, or how close the contractions are. The closer the contractions, the sooner the patient's going to deliver birth. So if you have a couple minutes in between contractions, you probably have some time to get the patient to the hospital. If the patient has contractions that are only 10 seconds apart, 20 seconds apart, the patient might be having the baby right there. So you might have to stay on scene and deliver the baby yourself. Anatomy and physiology of the female reproductive system. Female reproductive system includes ovaries, fallopian tubes, uterus, cervix, vagina, and breasts. The ovaries are two glands, one on each side of the uterus, similar in function to the male testes. Each ovary contains thousands of follicles, and each follicle contains an egg. Ovulation occurs approximately 2 weeks prior to menstruation. The fallopian tubes extend out laterally from the uterus, with one tube associated with each ovary. Fertilization usually occurs when a sperm meets the egg inside the fallopian tube. The fertilized egg continues to the uterus, where if implantation occurs, it develops into an embryo and then a fetus and grows until the time of delivery. The uterus is a muscular organ that encloses and protects the developing fetus as it grows for approximately 9 months. Produces contractions during labor, helps to push the fetus through the birth canal. The birth canal is made up of the vagina and the lower third of the uterus called the cervix. Okay, so this is the amniotic fluid. This provides protection for the baby while it's inside. The vagina is the outermost cavity of the female reproductive system and forms the lower part of the birth canal, completes the passageway from the uterus to the outside world. The perineum is the area of skin between the vagina and the anus. The breast produces milk that is carried through small ducts to the nipple to provide nourishment to the newborn once it is born. Early signs of pregnancy in the breast include increased size and tenderness. The placenta attaches to the uterine wall and connects to the fetus by the umbilical cord. The placental barrier consists of 2 layers of cells. Anything ingested by a pregnant woman has the potential to affect the fetus. Nutrients, oxygen, waste, carbon dioxide, many toxins, most medications. So this is why they tell you, if you're pregnant, don't drink or smoke, because it could be potentially passed on to your newborn. And then also any medications you might take, such as even pain pills. It's going to cross that placenta barrier, and possibly, especially with pain medications, it might slow your newborn's respiratory rate down, which could lead to serious complications. So after delivery, the placenta separates from the uterus and delivers. The umbilical cord is the lifeline of the fetus. The umbilical vein carries oxygenated blood from the placenta to the fetus. The umbilical arteries carry deoxygenated blood from the fetus to the placenta. The fetus develops inside a fluid-filled bag-like membrane called the amniotic sac. It contains about 500 to 1,000 milliliters of amniotic fluid, or 1 liter. Helps insulate and protect the fetus. The fluid is released in a gush when the sac ruptures, usually at the beginning of labor. So we have OB kits in our rig. You also have one in your jump bag. This is filled with a gown, sterile gloves, face mask, face shield, everything you're going to need, because it's going to get messy. So make sure you have that stuff on before the baby's delivered. Normal changes in pregnancy. Many normal changes occur in the body that are not all directly related to the reproductive system: respiratory, cardiovascular, musculoskeletal. Hormone levels increase to support fetal development and prepare the body for childbirth. As the fetus develops and grows, the uterus also grows. As the size of the uterus increases, so does the amount of fluid it contains. The uterus and organs are shifted from their normal position. Rapid uterine growth occurs during the second trimester. As the uterus grows, it pushes up on the diaphragm and displaces it. Respiratory capacity changes with increased respiratory rates and decreased minute volume. So blood volume gradually increases to allow for adequate perfusion of the uterus, prepare for blood loss during childbirth. Number of red blood cells increases, speed of clotting increases, patient's heart rate increases up to 20%. In the third trimester, there's an increased risk of vomiting and potential aspiration following trauma due to changes in the gastrointestinal motility and the displacement of the stomach upward. So this is why in the third trimester, we don't lay pregnant patients flat. We lay them on their left side, because this also puts pressure on the aorta, the vena cava. So you're going to get less blood flow back to the heart. That's going to cause the patient to pass out. So be very careful about laying patients on their laying them on their back when you're doing this. Changes in the cardiovascular system and the increased demands of supporting the fetus increase the workload of the heart. Not all women are healthy when they begin pregnancy. Cardiac compromise is a life-threatening possibility. Weight gain during pregnancy is normal. Weight gain will challenge the heart and impact the musculoskeletal system. The joints become looser or less stable. Changes in the body's center of gravity increases the risk of slips and falls. Complications of pregnancy. Most pregnant women are healthy. Some may be ill when they conceive or become ill during pregnancy. Use oxygen to treat any heart or lung disease in a pregnant patient. So diabetes develops during pregnancy in many women who have not had it previously. Gestational diabetes usually resolves after delivery. Treatment is the same as for any other patient with diabetes. Diet, exercise, or insulin injections. So always take a blood sugar from a pregnant patient. Ask them if they have been tested for gestational diabetes. This could lead into possible preeclampsia and eclampsia. So hypertensive disorders. Preeclampsia is a pregnancy-induced hypertension. Can develop after the 20th week of gestation. Signs and symptoms include severe hypertension, severe persistent headache, visual abnormalities, swelling in the hands and feet, and anxiety. Eclampsia is characterized by seizures that occur as a result of hypertension. To treat seizures caused by eclampsia, lie the patient on her left side, maintain her airway, administer supplemental oxygen if necessary. If vomiting occurs, suction the airway, provide rapid transport, and call for ALS. Transporting the patient on her left side can also prevent supine hypotensive syndrome, caused by compression of the descending aorta and the inferior vena cava by the pregnant uterus when the patient lies supine. Hypotension may result. So this is what I was talking about a few minutes ago. So try and not lay a pregnant patient, especially in her third trimester, on her back. Put her on her left side. This also take pressure off the aorta and the inferior vena cava. So bleeding, internal bleeding may be a sign of ectopic pregnancy. An embryo develops outside the uterus, most often in a fallopian tube. So, leading cause of maternal death in the first trimester is an internal hemorrhage following a rupture of an ectopic pregnancy. Consider the possibility in a woman who has missed a menstrual cycle and complains of sudden severe pain in the lower abdomen. Hemorrhage from the vagina that occurs before labor begins may be very serious, may be a sign of spontaneous abortion or miscarriage. An abrupto placenta. Placenta separates prematurely from the wall of the uterus. In placenta previa, the placenta develops over and covers the cervix. Okay, so we see a couple different pictures of the bleeding. Okay. So abortion, passage of the fetus and placenta before 20 weeks may be spontaneous or induced. Most serious complications are bleeding and infection. If the woman is in shock, treat and transport her promptly to the hospital. Abuse. Pregnant women have an increased chance of being victims of domestic abuse, of domestic violence and abuse. Abuse increases the chance of spontaneous abortion, premature delivery, low birth weight. The woman is at risk from bleeding, infection, and uterine rupture. Use a calm, professional approach. Pay attention to the environment for any signs of abuse. Talk to the patient in a private area, away from the potential abuser if possible. Substance abuse. Effects of addiction on the fetus include prematurity, low birth weight, severe respiratory distress, death. Fetal alcohol syndrome describes the condition of infants born to the women who have abused alcohol. Pay special attention to your safety. Wear eye protection, a face mask, and gloves at all times. Look for clues that you're dealing with an addicted patient. The newborn will probably need immediate resuscitation. Special considerations for trauma and pregnancy. With a trauma call involving a pregnant woman, you have two patients, the woman and the unborn fetus. Trauma to a pregnant woman may have a direct effect on the fetus. Pregnant women may be victims of assaults, motor vehicle crashes, shootings. Pregnant women also have an increased risk of falling. Pregnant women have an increased amount of overall total blood volume and a 20% increase in heart rate. They may experience a significant amount of blood loss before you will see signs of shock. Uterus is vulnerable to penetrating trauma and blunt injuries. When a pregnant woman is involved in a motor vehicle crash, severe hemorrhage may occur from injuries to the uterus. Trauma is the leading cause of abrupto placenta. Common symptoms include vaginal bleeding and severe abdominal pain. So always ask the patient if they have any abdominal pain or if there's any discharge. See if you see any fluid, any bleeding. You could always ask if there's a female on scene. If you have a female partner or a female firefighter, you could ask them to visualize for you. Improper positioning of the seatbelt can result in injury to a pregnant woman and the fetus. Carefully assess a pregnant woman's abdomen and chest for seatbelt marks, bruising, and obvious trauma. Cardiac arrest. Your focus is the same as with other patients. Perform CPR and provide transport. Notify the receiving facility personnel that you are en route with the pregnant trauma patient and cardiac arrest. Assessment and management. Your focus is on the woman. Suspect shock based on the MOI. Be prepared for vomiting and aspiration. Attempt to determine the gestational age to assist you with determining the size of the fetus and the position of the uterus. Follow these guidelines when treating a pregnant trauma patient. Maintain an open airway. Administer high flow oxygen. Ensure adequate ventilation. Assess circulation. Transport the patient on her left side. So cultural value considerations. Cultural sensitivity is important. Women of some cultures may have a value system that will affect the choice of how they care for themselves during pregnancy, how they have planned the childbirth process. Some cultures may not permit a male healthcare provider to assess or examine a female patient. Respect these differences and honor requests from the patient. A competent, rational adult has a right to refuse all or any part of your assessment or care. So just like with any call, if a patient's alert and oriented times 4 and they do not wish to have medical treatment, you cannot touch them or treat them. You have to let the patient make the decision on their own. Teenage pregnancy. The United States has one of the highest teenage pregnancy rates. Pregnant teenagers may not know they are pregnant or may be in denial. Respect the teenager's privacy. Assess and obtain her history away from her parents. So teenagers might not be totally forthcoming with you guys when you guys are asking questions on scene. If you suspect a patient might be pregnant, pull them off to the side. Ask them in the back of an ambulance. Is there a possibility you might be pregnant? They're probably going to be a little more truthful with you there. And then you let the hospital know. And the hospital could go from there. Patient assessment. Childbirth is seldom an unexpected event, and there are occasions when it becomes an emergency. Dispatcher usually asks simple questions to determine whether birth is imminent. Premature contractions may be caused by trauma or medical conditions. Scene size up. Scene safety. Take standard precautions. Gloves and eye and face protection are minimum if delivery has already begun or is complete. Time allows, a gown should also be used. Consider calling for additional resources. So remember, you guys have OB kits in the car or in the rig, also in your jump bags. Pull that out. That's going to have everything you guys need. All your PPE, all your standard precautions for pregnancy. Mechanism, injury, nature of illness. You will encounter pregnant patients who are not in labor, so it is important to determine the MOI or NOI. Do not develop tunnel vision during a call. Falls and necessity for spinal mobilization must be considered. So primary assessment, form of general impression. So what does a patient look like when you get up, when you walk on scene? Scan the area. General impression should tell you whether the patient is in active labor or whether you have time to assess and address other possible life threats. Perform a rapid examination. When trauma or other medical problems present, evaluate these first. Airway and breathing. Life-threatening conditions with the woman's airway and breathing are usually not an issue during birth. If motor vehicle crash, assault, or medical condition may cause a life threat, assess the airway and breathing to ensure they are adequate. Circulation. Use external and internal bleeding are potential life threats and should be assessed early. Blood loss after delivery is expected, but significant bleeding is not. Assess for and treat life-threatening bleeding. Assess for skin color, temperature, and moisture. Check the pulse. Transport decision. Delivery is imminent. Prepare to deliver at the scene. Ideal place to deliver is in the ambulance or the woman's home. The delivery is not imminent. Prepare the patient for transport. Provide rapid transport for pregnant patients who have significant bleeding and pain, are hypertensive, or having a seizure, have an altered mental status. History taken. Obtain a thorough obstetric history. Her expected due date, any complications that she is aware of, if she has been receiving prenatal care, a complete medical history. Obtain a sample history. Pertinent history should include questions related specifically to prenatal care. Determine the due date, frequency of contractions, a history of previous pregnancies and deliveries, possibility of multiples, and if she has taken any drugs or medications. If her water is broke, ask whether the fluid was green due to meconium staining. So also you're asking how many times has the patient been pregnant? How many kids does this patient have? Were there any complications with the kids? Any miscarriages as well? Secondary assessment. Physical examinations. Assess the major body systems as needed. Emphasis on the chief complaint. Assess for fetal movement. If the patient is in labor, focus on contractions and possible delivery. If you suspect that delivery is imminent, check for crowning. Crowning is you're looking for the baby's head, see if the baby's head's coming out. That's going to be a good visual clue to let you know the baby's coming. So you're going to have to deliver on scene. Vital signs: pulse, respirations, skin color, temperature and condition, and BP. Be especially alert for tachycardia and hypo or hypertension. Hypertension, even mild, may indicate more serious problems. Reassessment. Repeat the primary assessment. Obtain another set of vital signs. Check interventions and treatments. In most cases, childbirth is a natural process that does not require your assistance. When childbirth is complicated by trauma, any interventions you provide the patient will benefit the fetus. Communication and documentation. Delivery is imminent. Notify staff at the receiving hospital. Provide an update on the status of the woman and the newborn after delivery. If delivery does not occur within 30 minutes, provide rapid transport. For a pregnant patient with a complaint unrelated childbirth, be sure to include the pregnancy status in your radio report, the number of weeks of gestation, her due date, and any known complications of the pregnancy. If delivery occurs in the field, you will have two patients' care reports to complete. So 2 PCRs, one for the mom and one for the kid. So stages of labor, there are going to be 3. Dilation of the cervix, delivery of the fetus, and then delivery of the placenta. So once a baby gets delivered, there's still that 3rd stage of labor. So be aware of that. So first stage begins with the onset of contractions and ends when cervix is fully dilated, usually the longest stage, lasting an average of 16 hours. Uterine contractions become more regular and last about 30 to 60 seconds each. Frequency, intensity increase. So remember, when the contractions get closer and closer together, that means delivery is coming. So try and time those contractions. Look at your watch. See how far apart they are. Labor is generally longer in a prima gravida, first pregnancy, than in multigravida. A woman may experience preterm or false labor or Braxton Hicks contractions. You should provide transport for the patient. Remember, you can't differentiate in the field if they're real contractions or Braxton Hicks contraction. Always transport the patient. Have them get looked at in the L&D. Okay, and then also for patients who have history of multiple pregnancy or multiple births, they're going to give birth a lot faster. So be aware of that as well. So you got a little table here, false labor versus true labor. Sometimes it's hard to differentiate in the field and just transport and try and make the patient as comfortable as possible. So some women experience a premature rupture of the amniotic sac. Patient may or may not go into labor. Provide supportive care and transport. The head of the fetus descends into the woman's pelvis as it positions for delivery. This descent is called lightning. Second stage begins when the fetus begins to encounter the birth canal. Ends when the newborn is born. Uterine contractions are usually closer together and last longer. The perineum will bulge significantly, and the top of the fetus's head will appear at the vaginal opening. This is called crowning. Third stage begins with the birth of the newborn and ends with the delivery of the placenta. The placenta must completely separate from the uterine wall. It may take up to 30 minutes. So be aware of this. If the placenta hasn't been delivered after a few minutes, it might still come out later. Take the placenta with you as well. Doctor is going to want to look at that. So preparing for delivery. Consider delivery at the scene when delivery is imminent. Will occur within a few minutes. A natural disaster, inclement weather, or other environmental factor that makes it impossible to reach the hospital. Okay. So determine if delivery is imminent. Ask the patient, how long have you been pregnant? When are you due? Is this your first baby? Are you having contractions? How far apart? How long do they last? Have you had any spotting or bleeding? Has your water broken? Do you feel as though you need to have a bowel movement? Do you feel the need to push? To determine potential complications, ask, were any of your previous deliveries by a cesarean section? Have you had any problems in this or any previous pregnancies? Do you use drugs, alcohol, or take any medications? Is there a chance of multiple deliveries? And does your physician expect complications? The patient says that she is about to deliver, she has to move her bowels or feels the need to push, she should prepare for delivery. Does she have an extremely firm abdomen? Visually inspect the vagina to check for crowning. Once labor has begun, it cannot be slowed or stopped. Never attempt to hold the patient's legs together. Do not let her go to the bathroom. Remember, if you deliver at the scene, you are only assisting the woman with the delivery. Your emergency vehicle should always be equipped with a sterile emergency OB kit. So like I said, it's going to come with all this stuff. Everything that you're going to need for a childbirth for you and the patient. It's going to come in this little pack. You're also going to have a bulb syringe to suction out the baby's mouth if needed. Probably going to come with a blanket as well. So here's your bulb syringe. Kind of hard to tell. It kind of blends in. It's right here. And then also probably a little cap or a little beanie for the patient's head as well. Keep them warm. Because remember, children do not tolerate or cannot regulate their body temperature very well. So you want to keep them warm. Dry them off and keep them warm. Patient position. Preserve the patient's privacy. Place the patient on a firm surface padded with blankets, sheets, and towels. Elevate the hips about 2 to 4 inches. Support the head, neck, and upper back. Have her keep her legs, hips, and hips flexed with her feet flat and her knees spread apart. Preparing the delivery field. Place towels or sheets on the floor around the delivery area. Open the OB kit carefully. Put on sterile gloves. Use the sterile sheets and drapes from the OB kit to make a sterile delivery field. So this is what it's going to look like. Have the patient set up a little bit. Place a sterile sheet underneath the patient, and then prepare for delivery. Delivery. Your partner should be at the patient's head to comfort, soothe, and reassure. If the patient will allow it, apply oxygen. Continually check for crowning. Some patients experience precipitous labor and birth. Position yourself so that you can see the perineal area at all times. Time the patient's contractions. Remind the patient to take quick, short breaths during each contraction, but not to strain. Between each contractions, encourage the patient to rest and breathe deeply through her mouth. Delivering the head. Observe the head as it exits the vagina. Support the head with your gloved hand as it rotates. Apply gentle pressure across the perineum with a sterile gauze pad to reduce the risk of perineal tearing. Be prepared for the possibility of the patient having a bowel movement. Do not poke your fingers into the newborn's eyes or fontanelles. Unruptured amniotic sac. If the amniotic sac does not rupture by the time the head is crowning, it will appear as a fluid-filled sac emerging from the vagina. It will suffocate the fetus if not removed. You may puncture the sac with a clamp or tear it by twisting it between your fingers. Clear the newborn's mouth and nose immediately. So remember, this is why you have the bulb syringe. You're going to actually press down or collapse the bulb and then stick it in the patient's mouth or nose and then let the bulb inflate, and it's going to go ahead and suction out like that. Okay, make sure their mouth and nose are clear, and continuously monitor. Umbilical cord around the neck. As soon as the head is delivered, use one finger to feel around whether the umbilical cord is wrapped around the neck. Usually you can slip the cord gently over the delivered head. If not, you must cut it. Once the cord is cut, attempt to speed delivery. Delivering the body. Once the head is born, the body usually delivers easily. Support the head and upper body as the shoulders deliver. Do not pull the fetus from the birth canal. The newborn will be slippery and covered in vernix caseosa. Post-delivery care. If the mother is able and willing, place the newborn on her abdomen so skin-to-skin contact can begin immediately. Dry off the newborn and wrap him or her in a blanket or towel. Wrap the newborn so only the face is exposed. So remember, you want to keep the patient warm. Wipe down all that excess fluid, and then go ahead and throw a hat on. You can pick up and cradle the newborn if local protocols specify. Keep newborn at the level of the woman's vagina until the umbilical cord is cut. Always keep the head slightly downward to help prevent aspiration. Wipe the mouth with a sterile gauze pad as needed. Once the cord has stopped pulsing, clamp and cut the cord. Obtain the 1-minute Apgar scale. Deliver the placenta. Your job is only to assist. The placenta delivers itself usually within a few minutes of the birth. Never pull on the end of the umbilical cord. Let it come out naturally. You might rupture the placenta or the umbilical cord. This might cause an infection in the pregnant woman, so be very careful. You can help to slow bleeding by gently massaging the woman's abdomen with a firm circular kneading motion. So a patient's going to have what's called a funnus. It's going to be like a rock hard almost like a small little rock. So you're just going to have to massage that, and that's going to help slow the bleeding down a little bit too. Record the time of the birth in your patient care report. The following are emergency situations. More than 30 minutes elapsed and the placenta has not delivered. There's more than 500 milliliters of bleeding before delivery of the placenta. There's significant bleeding after the delivery of the placenta. Neonatal assessment and resuscitation. Follow standard precautions. Always put on gloves before handling a newborn. Newborn will usually begin breathing spontaneously within 15 to 30 seconds after birth. Heart rate will be 120 beats per minute or higher. If you do not observe these responses, gently tap or flick the soles of the feet or rub the back. Many newborns require some form of stimulation, including positioning the airway, drying, warming, suctioning, or tactile stimulation. So it's a little table for you guys to remember when you want to intervene and when you want to just let the patient breathe on their own. To maximize the effects of these measures, position the newborn on his or her back with the head down and the neck slightly extended. If necessary, suction the mouth and then the nose. In addition to drying the head, back, and body with dry towels, and rub the back and flick or slap the soles of the feet. Additional resuscitation efforts. Observe the newborn for spontaneous respiration, skin color, and movement of the extremities. Evaluate the heart rate at the base of the umbilical cord or brachial artery, or by listening to the newborn's chest with a stethoscope. The heart rate is the most important measure in determining the need for further resuscitation. So remember, you want to have that heart rate over 100 beats a minute. If the patient's heart rate is over 100 beats, just go ahead and keep the patient warm. Continuously reassess. Anything below 100 beats, 60 to 100 beats, you're going to assist ventilations with BVM. And then fewer than 60 beats a minute, you're going to start chest compressions or call for ALS backup. If chest compressions are required, use a hand encircling technique for two-person resuscitation. Perform BVM ventilation during a pause after every third compression using a ratio of 3 to 1, 120 actions per minute, 90 compressions, and 30 ventilations. And so this is how you're going to do CPR for a newborn. You're going to have enough room to go ahead and put your hands behind your chest. Hands encircling the whole body, and go ahead and put 2 thumbs down right in the center where you would do CPR on an adult, and go ahead and do compressions that way. Any newborn that requires more than routine resuscitation requires transport to hospital with a level 3 neonatal ICU. About 12 to 16% of deliveries are complicated by the presence of meconium. Consider quickly suctioning the newborn's mouth, then nose after delivery before providing rescue ventilations. The Apgar Score, standard scoring system used to assess the status of a newborn, assigns a number valued of 5 areas: appearance, pulse, grimace or irritability, activity or muscle tone, respirations. The total of the 5 numbers is the Apgar score. A perfect score is 10. Calculate the Apgar score at 1 minute and 5 minutes after birth. So here's your Apgar score. So appearance, pulse, grimace, activity, respiration. You're going to get either a 2, a 1, or a 0 for each category. Okay, you guys should know this. This is going to be on your test. You guys should know this as well as your GCS score as well. So you're doing an Apgar score at 1 minute and 5 minutes after birth. Assessing a newborn, calculate the Apgar score. Stimulation should result in an immediate increase in respirations. If the newborn is breathing well, assess the pulse. Assess oxygenation via pulse oximetry and observe for central cyanosis. Request a second unit if the newborn is in distress and will require resuscitation. In situations where assisted ventilation is required, use a newborn BVM. If the newborn does not begin breathing on his or her own, Does not have an adequate heart rate, continue CPR and rapidly transport. So breech delivery. Most infants are born head first. Occasionally buttocks are delivered first, called a breech presentation. So an easy way to remember is B and B. So a breech presentation is when the buttocks are delivered first. Breech deliveries usually take longer, so you often have time to transport the pregnant woman to the hospital. The buttocks have passed through the vagina. The delivery has begun. Provide emergency care and call for ALS backup. Consult medical control to guide you. Preparing for breech delivery is the same as for a normal childbirth. Position the pregnant woman, prepare the OB kit, place yourself and your partner as you would normally. Allow the buttocks and legs to deliver spontaneously, supporting them with your hand. The head is almost always face down and should be allowed to deliver spontaneously. Make a V with your gloved fingers and position them in the vagina to keep the walls from compressing the fetus's airway. Okay. So on rare occasions, presenting part of the fetus is a single arm, leg, or foot, called a limb presentation. Any fetus with a limb presentation cannot be delivered in the field. Usually surgery is needed. Transport immediately. If a limb is protruding, cover it with a sterile towel. Never try to push it in or pull on it. Place the patient on her back with her head down and pelvis elevated. Prolapse of the umbilical cord must be treated in the hospital. Umbilical cord comes out of the vagina before the fetus. The fetus's head will compress the cord and cut off circulation. Do not push the cord back into the vagina. Place the pregnant woman supine with the foot off the cot, raised higher than the head, with her hips elevated or in the knee chest position. Insert your gloved hand into the vagina and push the fetus's head away from the umbilical cord. Transport rapidly. So remember, don't push the umbilical cord back into the vagina. Just insert your gloved hand on the patient's head and try and keep him away. Get pressure off that umbilical cord. Spina Bifida, developmental defect in which a portion of the spinal cord or meninges may protrude outside the vertebrae. Seen on the newborn's back. Cover the opening area of the spinal cord with a sterile, moist dressing. Maintenance of body temperature is important when applying moist dressing. Multiple gestation. Twins occur once in every 30 births. Always be prepared for more than one resuscitation and call for assistance. Twins are smaller than single fetuses and delivery is typically not difficult. About 10 minutes after the first birth, contractions will begin again and the birth process will repeat itself. The second one is usually be born within 45 minutes of the first. The procedure is the same as that for a single fetus. There may only be one placenta, there may be two. Record the time of birth of each twin separately. Twins may be so small that they may look premature. Handle carefully and keep them warm. So premature birth. A normal full-term single newborn will weigh about 7 pounds at birth. Any newborn who delivers before 8 months or 36 weeks or weighs less than 5 pounds at birth is considered premature. So remember those two ones. So 8 months and less than 5 pounds are going to be considered premature, or less than 36 weeks. So a premature newborn is smaller and thinner, and the head is proportionally larger. The vernix caseosa will be absent or minimal. There will be less body hair. Premature newborns require special care to survive, often require resuscitation efforts, which should be performed unless it's physically impossible. With such care, premature newborns as small as 1 pound have survived and developed normally. Postterm pregnancy. Pregnancies lasting longer than 42 weeks. Fetuses can be larger, sometimes weighing 10 pounds or more. Can lead to problems with the woman and fetus, a more difficult labor and delivery. So increased chance of injury to the fetus, increased likelihood of cesarean section. Women is at high risk for perineal tears and infection. Post-term newborns have increased risk of meconium aspirations, infection, and being stillborn. Newborns may not have developed normally. Fetal demise. You may deliver a fetus who had died in the woman's uterus before labor. Onset of labor may be premature, but labor will progress normally in most cases. If an intrauterine infection caused the demise, you may note a foul odor. Do not attempt to resuscitate an obviously dead neonate. Delivery without sterile supplies. You may have to deliver a newborn without a sterile OB kit. You should always have eye protection gloves and a mask with you. Carry out the delivery as if sterile supplies were available. Use freshly laundered sheets and towels. Try and make your area as sterile as possible for the baby and for your patient. So wipe the inside of the newborn's mouth with your finger. Do not cut or clamp the umbilical cord. Wait till that umbilical cord has stopped pulsing. As soon as the placenta delivers, wrap it in a clean towel and transport. Keep the placenta and newborn at the same level and keep the newborn warm. So postpartum complications. If bleeding continues after delivery of the placenta, continue to massage the uterus. Check your technique and hand placement if bleeding continues. Excessive bleeding is usually caused by the uterine muscles not fully contracting. Cover the vagina with a sterile pad. Change the pads as often as possible. Do not discard any blood-soaked pads. Administer oxygen, monitor vital signs, and transport the patient immediately. Postpartum patients are at an increased risk of an embolism. Most commonly, a pulmonary embolism results from a clot that travels through the bloodstream and becomes lodged in the pulmonary circulation. Consider when a woman complains of sudden difficulty breathing or shortness of breath following delivery. So review, first stage of labor ends when? What are the 3 stages of labor? When does the second stage of labor start? So A, the first stage of labor begins with the onset of contractions and ends when the cervix is fully dilated. However, since cervical dilation cannot be assessed in the field, this first stage of labor is considered over when the presenting part of the baby is visible at the vaginal opening or crowning. 23-year-old woman who's 24 weeks pregnant with her first baby complains of edema to her hands, a headache, and visual disturbances. When you assess her vital signs, you note that her blood pressure is 160/94. She is most likely experiencing what? What are the 3 signs and symptoms of this condition? So B, preeclampsia, also called pregnancy-induced hypertension, usually develops after the 20th week of gestation. Most commonly affects prima gravida, first pregnancy patients. It is characterized by headache, visual disturbances, edema of the hands and feet, anxiety, and high blood pressure. Preeclampsia can lead to eclampsia, a life-threatening condition that's characterized by seizures. So be very careful on these patients. They might have seizures. You're transporting a woman who's 8 months pregnant to prevent supine hypotensive syndrome. How would you position this patient? We've talked about this about 3 times, at least. So D, to prevent supine hypotensive syndrome, the patient must be positioned on her left side. This stops the weight of the fetus from compressing the inferior vena cava, which can cause low blood pressure. So immediately after delivery of the infant's head, you should... What's the first thing in your primary assessment? So D, immediately following delivery of the infant's head, you should check position of the umbilical cord to make sure it is not wrapped around the baby's neck, nuchal cord. If nuchal cord is not present, suction the infant's mouth and nose. Excuse me. Upon delivery of the baby's head, you note that the umbilical cord is wrapped around its neck. You should So B, if the umbilical cord is wrapped around the baby's neck, you should make one attempt to gently remove the cord from around the baby's neck. If this is not possible, the cord should be clamped and cut. Keep the cord moist. Administer high flow oxygen to the mother and transport at once. The need for and extent of newborn resuscitation is based on So D, the need for an extended newborn resuscitation is based on respiratory effort, heart rate, and skin color. The Apgar score is not used to determine if resuscitation is needed. The first score is not assigned until the newborn is 1 minute of age. Resuscitation, if needed, should commence immediately. So if you notice a problem, fix it immediately. The 1 minute Apgar score of a newborn reveals that the baby has a heart rate of 90 beats a minute, a pink body but blue hands, feet, and rapid respirations. The baby cries when the soles of its feet are flicked and resists attempts to straighten out his legs. You should assign an Apgar score of what? So you guys need to know your Apgar score. What it goes up to. What's the best score you could have? What's the worst score you could have? So the Apgar score, which is obtained at 1 and 5 minutes after birth, assigns a numeric value to the following 5 areas: appearance, pulse, grimace, activity, and respirations. A heart rate below 100 is assigned to 1. Pink body with blue hands and feet is 1. Rapid respirations is 2, and a strong crying reaction to painful stimulus is 2. And resistance against an attempt to straighten out the hips and knees is 2. Added together, the Apgar score for this infant is 8. The most effective way to prevent cardiopulmonary arrest in a newborn is to So C, cardiopulmonary arrest in infants and children, including newborns, is most often the result of respiratory arrest. Therefore, ensuring adequate oxygenation and ventilation at all times is critical. It is also important to maintain the infant's body temperature and to prevent hypothermia. While assisting a woman in labor, you visualize her vaginal area and see an arm protruding from her vagina. If she tells you that she feels the urge to push, you should Can you deliver this in the field? Should you try and deliver this in the field? So A, limb presentations do not deliver in the field, period. If the mother feels the urge to push, instruct her to stop. She should pant instead, cover the protruding limb with a sterile towel, and administer high flow oxygen to the mother and transport immediately. Delivery must take place in the hospital. This patient needs surgery, most likely. A newborn is considered to be term if it is born after and before what? So B, a term gestation ranges between 37 and 42 weeks. An infant who is born before 37 weeks or weighs less than 5 pounds, regardless of gestational age, is considered premature. An infant born after 42 weeks is considered past due. So this is typically when a patient is going to give birth between that 37 and 42 week period.